All right, we're recording. Okay, so all I was saying was our circulatory system is described as being closed because it doesn't have a direct exposure to the external environment. Our systemic circulation is responsible for delivering oxygen and nutrients to all of the tissues and cells in the body. And our pulmonary circulation is driven by the right side of the heart, delivering deoxygenated blood to the lungs to be oxygenated and returned to the left side of the heart. So that when the left side pumps, it delivers oxygenated blood all over the body, systemic circulation. And we know that when we look at the vessels, when we leave the heart, we leave through the aorta, large, medium, small arteries. And pressure goes from big to less. Arterioles to the capillaries, out the other end through venules, and then we're going to go small, medium, large veins to the vena cava, both the superior and the inferior, and in between we have the heart. So we go that way, we go that way. Okay, so our pressure, if we were to draw a graph from the aorta to the vena cava, our pressure kind of goes like this, gets progressively less and less. So on the vein side, these veins are described as capacitance vessels. In other words, they expand and receive large volumes of blood, probably in the vicinity of 60% of total blood volume when we're at rest is going to be found on the venous side. Remember, the veins were dependent on skeletal muscle pumps and one-way valves. For venous return. And the aorta and some of the larger arteries are referred to as resistance vessels. And then when we get down to the smaller arteries and arterioles, those were distributive because that's when we spread out, and they're under more specific control from the sympathetic division of the autonomic nervous system and influence blood pressure through dilation or constriction. Resistance vessels are more about elasticity. The volume of blood that's introduced to the aorta stretches the aorta returns back elasticity to its resting diameter and pushes the blood into the next group of vessels. That's resistance, and their primary characteristic is elasticity. When we look at distributive vessels, they're the ones that are going to spread the distribution of blood to the different parts of the body, and they're the ones that are under more direct control by the sympathetic division of the autonomic nervous system to either vasodilate or vasoconstrict to direct blood to the areas we need it most. In fight or flight, that would include skeletal muscles and the central nervous system as well as the heart. In rest and digest, it would change and be more directed towards digestive system and the kidneys, for example. Does that make sense? Are we okay with that?
Yeah.
Okay. And then we describe our capillaries as exchange vessels. They are single cell layer thick with gaps between them that favor exchange. And that exchange will be driven by hydrostatic pressure and osmotic pressure differences. All stuff that we've talked about in either HAP 101 or HAP 201, right? So you just want to review a little bit about that, the organization of those blood vessels in that respect. The other thing to be aware of is that the blood vessels, whether we're talking about veins or arteries, are arranged in what are called layers or tunicas. The innermost layer is the tunica intima, which is composed mostly of a simple squamous epithelium called an endothelium. The tunica media is smooth muscle, and the tunica adventitia, or sometimes you'll see it as an externa, is mostly connective tissue. It's about protecting the rest of the blood vessel. If we looked at a vein or an artery, they both would be arranged with these three different levels of tissue. Our innermost the capacitance, that's supposed to show up as being a little bit larger. Okay, so if we looked at two vessels that on the outside look very similar, we would see that the arrangement of these three layers is going to be a little different. The tunica intima is pretty much going to be a simple squamous endothelium, but the biggest difference will be in the next layer. In the vessels that are under the greatest pressure, we're going to have a thicker layer of tunica media. That's the arteries. So this is going to be made up of smooth muscle cells, and this one is made up of smooth muscle cells, but in a vein, the tunica media is much thinner. And then our outermost layer is our tunica externa. In an artery, it's a little thinner than it is in a vein. And again, the connective tissue layer in a vein will have a little more elasticity for its capacitance, its ability to hold and be stretched in response to the volume of blood that's in it. So we look at these two vessels, and from the outside, they got about the same diameter. They look like they're about the same diameter, but on the inside, we can see that the diameter of the vein is a bit larger because our artery has a thicker tunica media. Okay, so the lumen in an artery is a bit smaller. That's a vessel that's under higher pressure, though, so delivery is going to be pretty effective. And our lumen diameter in our vein is bigger on an equally sized vessel from the outside. You follow me on that?
Yeah.
Okay. And in a capillary, what we'll notice in a capillary is that the tunica intima is interrupted. It's got gaps. In particularly leaky capillary networks, those gaps are called fenestrations. And we have some gap junctions, and we have some spaces that allow for delivery through those spaces at a capillary, where our hydrostatic pressure is greater than our osmotic pressure. And at the capillary on the arterial side, when hydrostatic pressure is higher than osmotic pressure, we get filtration, movement out. Everything but the largest cells and largest proteins will be pushed out and then reabsorbed at the venous end so that we retain blood volume, at least most of it, to return to the heart for the next cycle in the circulation. And all of this is dependent on a measurable we call blood pressure. And blood pressure is a function of cardiac output times total peripheral resistance.
Sorry, what is it?
Total peripheral resistance, TPR. Is that what you're asking?
Yeah, and then the one before that.
Why is this doing this? I've lost my cardiac output, CO, cardiac output.
Okay, thank you.
Okay, I don't know why. Hopefully that's not going to be an issue. Okay, so blood pressure is a function of cardiac output times total peripheral resistance. Total peripheral resistance is dependent on blood vessel length, blood vessel diameter, and something we call blood viscosity, the thickness of blood. So if blood pressure is going to go up, then one or both of these factors goes up.
Oh, we can't see your screen.
You can't see my screen?
No.
Did it stop sharing? Share screen. What happened there? How about now?
Yes.
Yeah.
Okay. All right. So when we look at this equation, blood pressure is a function of cardiac output times total peripheral resistance. And total peripheral resistance is based on vessel length, vessel diameter, and blood viscosity. So if blood pressure goes up, that means one or both of these other factors must have gone up, right? Using this equation to figure out what happens to blood pressure. So if total peripheral resistance went up, then that must be because vessel length went up or vessel diameter got less or blood viscosity went up. You follow me on that?
Yeah.
Okay, so that should all be reviewed, right? We talked about this in HAP 201. And cardiac output was a function of stroke volume times heart rate. So if any one of these factors is changed in the directions that we've said, so we'd have to have all of these would have to be up, then the result is going to be an increase in blood pressure. If we drop all these things down, then blood pressure comes down. So that's how we can use this equation to predict what's going to happen, for example, in the symptoms of somebody. If somebody is obese, then they've added vessel length because fat is very vascular. So if you add vessel length, you've increased total peripheral resistance. Obesity causes an increase in blood pressure, and the reason is there's more vessel length. Does that make sense? We okay with that?
Yeah.
During fight or flight, your heart rate goes up, which means cardiac output goes up, which means what's going to happen to blood pressure?
Up.
Up, right. Okay, so that's the way to use this equation if you wanted to sort of think about, if you're trying to figure out what's going on in the body and you can figure out one of these factors, then you know what the effect is going to be on blood pressure. So we know that the autonomic nervous system affects blood pressure because the autonomic nervous system is either fight or flight or rest and digest. If it's fight or flight, then cardiac output goes up because we know that the sympathetic division targets the heart and causes the heart rate to go up. It also causes a number of blood vessels to constrict in certain areas that will cause blood pressure to go up as well. Now, others dilate, so it's a bit of a trade, but the net difference is going to be an increase in blood pressure. So all those things play a role. So when we look at blood flow, these are some factors that we can take into consideration for respect of blood flow. But also we can more generally look at factors that are either extrinsic, meaning they're outside the blood vessel, or they're intrinsic. So when we talk about extrinsic mechanisms that are going to affect blood flow, that's going to be mostly the nervous system. And hopefully you recall from the nervous system that the autonomic nervous system is the nervous system that targets smooth muscle. And we know that the blood vessels of the circulatory system are potentially then targets for the autonomic nervous system, because that's where our smooth muscle is going to be. If we contract that smooth muscle, we get vasoconstriction. If we relax that smooth muscle, we get vasodilation. Right? And in particular, the parasympathetic division has no effect on blood vessels. There's no receptors for ACH on blood vessels. So that leaves us with the sympathetic division. Now, who can tell me what the neurotransmitter is for the sympathetic division targets? Anybody remember? Parasympathetic was ACH. Sympathetic? Nobody? Even after I write it out for you? So what's our neurotransmitter used by the sympathetic division to target its effectors?
Epinephrine,
Or?
norepinephrine.
That's right, norepinephrine. Those are often used interchangeably. In certain receptors respond more directly to one or the other, but basically we talk about them interchangeably. So we'll include both of them in our conversation here. Now, the interesting thing is that the sympathetic division releases the same neurotransmitter that can cause both vasoconstriction as well as vasodilation. Now, if it's the same neurotransmitter, how is it possible to have a different effect? What must be changing?
Is it the receptors?
Yeah, very good. It is going to be the receptors. So there's different categories of what we call adrenergic receptors. Adrenergic receptors are sensitive or matched with epinephrine. You know, the other name for epinephrine is adrenaline. So and adrenaline fit. Too bad they weren't called epinephrergic or something that helped that way. But that's where the terminology originates from. It's an adrenergic receptor matches with epinephrine or norepinephrine. So this is where we get slightly different effects, because we've got receptors that are described as either alpha or beta receptors. So when epinephrine matches with an alpha receptor, we're going to get one type of response. And when it matches with a beta receptor, we can get a different response. So when we talk about changes in the nervous system to their targets, you either change the messenger, ACH or epinephrine, or you can change the receptor. And that's going to give us a different response. So generally speaking, when we talk about alpha receptors, there are two main categories of alpha receptors, and there's two main categories of beta receptors. There's some other ones, but these are the main ones. So basically what we see with alpha-1 receptors match with epinephrine, and they're going to promote vasoconstriction In a lot of blood vessels, especially blood vessels associated with the GI tract, vasoconstriction in the GI and other cells not needed for fight or flight. So if we get vasoconstriction, we're going to get decreased flow to those tissues. Epinephrine targets the alpha 1s, decreased flow to the gut. We don't need the gut during fight or flight. Now, when it targets, when epinephrine matches up with the beta-2 receptors, we'll go with beta-2 in a different color. Beta-2 receptors, we get vasodilation, so opening up, vasodilation in blood vessels that are going to supply the heart. So those are otherwise known as the coronary arteries. As well as skeletal muscle and arteries to the central nervous system. All tissues that are going to help us in fight or flight. We also get vasodilation to the airways of the lungs, but that's not blood vessels. We're trying to stay with blood vessels here. The beta 1s, when epinephrine targets beta 1, it increases cardiac muscle function is the primary result of that. So think of fight or flight. We want to increase heart rate and strength and contraction. That's what we're talking about there. And in alpha 2s, we get sort of a smooth muscle mix of contraction. So it's mixed. So it's not really helping us much in terms of understanding what's important for fight or flight or changes to. So the main ones, when we look at these receptors, when we look at the general effect, the alpha 1s plus beta 2 receptors generally redirect blood flow to two tissues So alpha 1 and beta 2 receptors generally redirect blood flow to tissues that support the sympathetic nervous system response, fight or flight, and away from tissues that do not. Okay, so when you're in pharmacology, you might talk about beta blockers. I don't know if have you talked about beta blockers or blockers in general? Yes, no?
No.
Not yet, you're not into that yet. But you can see where that terminology comes from. So if we know that the beta receptors, for example, target the heart and blood vessels that supply the heart, then a beta blocker is going to prevent the heart from responding to the epinephrine. So it will spare the heart from increasing its rate or force of contraction. If the heart's already challenged, it's going to be blocked from responding to epinephrine. So that's not very good for you if you're trying to fight or flight, but it does protect the heart from overworking. That's where the concept comes from. So if we know a little bit about these receptors, then we know a little bit about what those medications as a group can do. So alpha-1 and beta-2 together, under the influence of epinephrine, increase blood pressure. So alpha and beta blockers will decrease blood pressure. So if it's part of the nervous system, and if it's coming from the nervous system, it would be described as an extrinsic mechanism affecting blood flow. If it comes from within the circulatory system, it's described as being an intrinsic mechanism that can affect blood flow. This is otherwise known as auto-regulation. So, for example, endothelial cells, so those are the cells that line the blood vessel, they can release a chemical messenger, hey, chemical messengers, something to think about, called nitric oxide. Nitric oxide is a local chemical messenger that promotes vasodilation. So if there was decreased flow in a vessel, the endothelial cells can release nitric oxide, promote vasodilation, which will increase the flow to those endothelin. So another type of messenger, but when this messenger gets released, it promotes vasoconstriction. So these are local factors. So the other thing is that increased flow really represents an increase in blood pressure. And what a blood vessel will do in response to an increase in blood pressure stretches the blood vessel wall, which reflects the So typically with smooth muscle, if you stretch it, there's a reflex mechanism that's initiated that causes it to contract. That's partly what's behind peristalsis, which is helping to move the blood along a blood vessel, and we know helps to move food along the digestive tract as well. Does that make sense? Are we okay with that? What do these dashed lines represent? Look at the arrows. What do the dashed lines represent?
Negative feedback.
Yeah. Negative feedback. Yay for negative feedback. Yay for homeostasis. So these are local factors affecting homeostasis of blood flow. Our initial stimulus was a decrease in blood flow. We released nitric oxide that caused vasodilation. Vasodilation gives us an increase in blood flow. And the reverse is true for these two examples. We had an increase in flow because of high blood pressure, caused a stretch on the blood vessel, which reflexly contracts to decrease the blood pressure, which decreases flow, negative feedback. And endothelin also causes a vasoconstriction, which will decrease flow. And together, these are all examples of how we regulate blood flow. We saw this when we talked about glomerular filtration rates and regulating flow through the glomerulus in order to maximize the filtration effectiveness, right, in the kidney. So this goes on through all the tissues. If a tissue is ischemic, then those cells will release nitric oxide along with the endothelial cells to cause vasodilation to try to fix that problem. So the tube that is a blood vessel is just, in some respects, is just like the digestive tract. Remember when we talked about the digestive tract, we said it was a long muscular tube. And it had different responsibilities in different parts of the muscular tube. Responsibilities like in the stomach, it was about mixing. And in the small intestine, it was about absorption. And in the large intestine, fine-tuning the absorption and then elimination. Right? But all the way along, it was a muscular tube. So what are we concerned about with a muscular tube? Blocking it, restricting it. In the case of the digestive system, we might be concerned about scarring it so it can't absorb. If we had a muscular problem, we can't mix, or peristalsis is interfered with. In the blood vessel, a lot of those same things apply. If we block a blood vessel, we're going to have a problem. If we restrict a blood vessel, we may have a problem. If we have a problem with contraction or relaxation of the smooth muscle wall, we may have a problem. Does that make sense? We follow that logic? Yes? No?
No.
Well, if you have a tube, doesn't matter if we're talking about the stomach, the digestive system, or a blood vessel, if you block it, we can't get blood past that spot. If it's a vein and we block it, we can't get blood past that spot, right? This is coming away from the heart, this is going back to the heart, but in both cases we have a blockage. That's not going to be good for circulation, right? If we have a problem signaling smooth muscle to either contract or relax, then we have a problem controlling blood flow through vasoconstriction or vasodilation. That's going to be a pathology. If we have a problem with the elasticity of the blood vessel, that's a pathology. Does that make sense? You follow that logic?
Yep.
Okay. So in digestion, the concept's the same, right? If you have a blockage, you can't get the food any further along. And one of two things is going to happen. If it's deep down in the digestive system, you're going to be constipated. If it's up higher in the digestive system, you're not going to absorb. And what you might even see is vomiting, right? To expel whatever there was there. Either way, we're not getting proper function. So in the blood vessel, the concept's the same. The results will be a little different. But if we look at obstruction in a blood vessel, it's going to be a little bit different depending on where the obstruction is. But basically what we're concerned about is either what's going to happen after the obstruction or what's happening before the obstruction. So in arteries, a block causes ischemia, right? In veins, a block is going to cause edema. So if we drew it like this, if we draw down to a capillary network, and then we come away from the capillary network, and we come back up towards the heart, okay? Blood flow is heading towards the tissues, right? If we're not sure, in this capillary network, we got a whole bunch of cells that are looking for oxygen and nutrients in order to make ATP. If we create a blockage here, then blood flow is either restricted or blocked completely. So that's going to lead us to ischemia. Now, if we have a blockage on the venous side, what that's going to do is cause a backflow. We can't get past this spot, so what's going to happen is we're going to get swelling, and that's ultimately going to lead to edema. You know, you can look at your grandma's ankles. If she's been sitting for a length of time, she's got swelling all around the ankles, edema, because her venous system is not pumping blood back effectively to the heart. And there may be a pathology involved with that, or it may be just related to loss of elasticity, loss of the mechanisms for venous return. Those mechanisms we talked about at the beginning of the day that include skeletal muscle pumps and good valves in the veins. Right? Does that make sense? So this is describing edema. On the venous side, it's backwards. And on the arterial side, it's a forward effect. Right? Forward, backward. Does that make sense? We okay with that when we're looking at obstructions in these two different vessels?
Yes.
Are you sure? If you have a question, ask a question. No, we're okay. We can keep going. We'll build on this. We'll build on this. So hopefully we will at least. So what do we call an obstruction in a blood vessel? A general term for an obstruction is called a thrombus. So a thrombus can happen either in a vein or an artery, but basically it's a situation where there's a stationary blood clot within a vessel. So in an arterial thrombosis, we're concerned about ischemia. In a venous thrombosis, we're concerned about edema. If there's inflammation, then we're going to add the suffix itis to it. So we could have thrombophlebitis. Now that's a lot of terminology there, but basically what it's saying is that we've got a blood clot that formed, phleb is a vein, so a blood clot that formed in a vein that's causing inflammation. Thrombophlebitis. So with thrombophlebitis, it depends whether it's deep or if it's superficial, but most of the time it's going to be found in a superficial vein. And anything that increases blood clotting, any injury to the vein wall or stasis, blood stasis, like sitting for a long period of time, that decreases flow, faulty vein valves, those sorts of things, or get this one, increased estrogen levels may increase your risk for a thrombophlebitis. And that's going to present itself as pain at the site of the blockage and swelling before the blockage. In other words, that backward effect behind the blockage. Tension in the vein. So if you touch it, it's going to be painful, it's tense. When a valve is weak and not closing properly, it's described as being incompetent. That term is used whether you're talking about the valves in the heart or in this case, valves in the veins associated where this particular thrombus has formed. So what else do we have to worry about? So clinically, we've already talked a little bit about this thrombophlebitis, but clinically, when we look at these, it's going to be a little bit different depending on whether it's found in an artery or a vein. So arterially, because we're concerned about ischemia, it's going to present with something called intermittent claudication. Intermittent claudication means that at rest it might be fine. There's no signs for ischemia or reduced blood flow to an area. But on exertion, on, for example, walking, it becomes a challenge that the blood vessel is unable to meet because it was partially blocked or completely blocked, and it now shows up with challenge. Because with challenge, there's an increased demand for oxygen and nutrients to make ATP, and it's not being met. So it starts to burn or starts to ache, and the person that's experiencing it will stop. If they stop and rest, it goes away. That's why it's described as being intermittent. On exertion or on challenge, it presents itself. On rest, it seems to go away. The tissue that is beyond the arterial blockage will be cool and cyanotic. I think everybody knows what that means, right? Cyanotic. What do we mean when we use the term cyanotic? Nobody's ever heard of that term? Cyanosis? Or somebody is cyanotic?
Is that like blue, like they turn
Yeah.
blue, purple?
Blue. Well, and realistically, maybe not blue, but pale. And certainly if it goes to extreme, if you look under fingernails or around your lips where there's less pigment in the skin, it will often look bluish. So that's describing cyanosis, which means that there's low oxygen in that area. So fits with what we'd expect with an arterial blockage. Now with venous, we already talked about what happens if it causes inflammation. So we could have it presents if inflamed, and we have that on the previous slide, so we know there will be tenderness and there'll be edema and all that stuff. but can be asymptomatic. Until the thrombus breaks and is released. So it's released and is allowed to float along in the lumen, the opening of the vein, and it's now known as an embolus. So a thrombus that breaks and is free floating is called an embolism or an embolus. And in a vein, what happens is here's a little vein and another little vein that join in to a bigger vein that joins with other big veins and gets progressively bigger as it goes back to the heart. So if it was blocked in this small vein but breaks away, now the embolus is able to float into progressively larger spaces along with the direction of flow until it goes all the way back to where? Where is it heading?
To the heart.
Yeah, to the heart. And when it gets to the heart through the vena cava, where's it going to go next? So it's going to enter the heart. We're going to exaggerate this entry point like that. Enters the right side of the heart, and where does it go to?
To the lungs.
Yes. And look what happens to the blood vessels in the lungs. They stop getting bigger and instead get smaller. So now it lodges in one of those vessels, and then we get ischemia to all the tissue that that part of the vessel was supposed to be exposed to. And we get decreased oxygen exchange. This is called a pulmonary embolism, and it's life-threatening. Right? So the blood vessels all the way back to the heart got bigger and bigger and bigger. It's not going to get trapped or stuck on its way back to the heart. It gets into the heart chamber. That's a pretty big space. Goes from the atrium to the ventricle, still pretty big space. Leaves through the pulmonary trunk, pretty big space. Pulmonary right, pulmonary left. Then we start to get to some smaller blood vessels. It gets stuck and it causes a problem beyond that spot. No more exchange of air across that area into the blood vessels, poor oxygen delivery on the other side. We got a life-threatening situation in front of us. So that we described as a pulmonary embolism. So this embolus can be thought of or described as a traveling clot. It broke off from a place where it was fixed, where it was growing initially, and is now free to float through progressively larger vessels until it hits a smaller one. So once it leaves right heart, right ventricle, it could cause the pulmonary embolism. If it somehow got through the pulmonary circulation and instead left from the left ventricle, if it leaves the left ventricle, then one of the things that can happen if it leaves the left ventricle is that it might end up in the coronary artery. Causing a heart attack, otherwise known as a myocardial infarction. That's what MI stands for there, if you were wondering. Or it could cause a blockage in the cerebral arteries, leading to a stroke. Do you follow me on that? Does that make sense with what we're talking about here? If you need me to explain it, I'll explain it, but if I don't hear from you, I guess it's okay, right?
Yeah, sounds good.
Okay, good. So we understand that the issue with this traveling clot is that when it stops, when it gets trapped, everything beyond that spot is not going to be able to be functioning effectively. If it's up in the lungs, we're not going to get air exchange. It'll present like trouble with breathing, and then probably because of the poor oxygen delivery on the other side can lead to deterioration systemically and create all kinds of life-threatening problems for us in that respect. Now, lots of times we're not going to get a full obstruction. Obstruction is pretty dramatic and pretty rare to happen, but we can get scenarios where the blood vessel spasms and, at least on a temporary basis, reduces blood flow beyond that portion of spasticity. So when we talk about vasospasms, that's a scenario where there's a sudden vasoconstriction causing a temporary ischemia. So some examples, there's a type of angina. Some of you may realize or know that angina is a general term for chest pain, and it's usually related to a problem with the heart, but doesn't technically have to be. But traditionally, we relate angina type pain as coming from a problem associated with the heart or the blood vessels that supply the heart. So there's a type of angina that's described as being a cyclic angina. In the textbooks, the guy that first identified it was a guy named Prinzmetal. So it's sometimes called Prinzmetal angina. Not a very good, helpful name because it doesn't describe anything, but at least with the word cyclic in front of it, it tells us that it is going to be variable in its presentation. And that's also a name that's sometimes associated with this type of chest pain. It's called variant angina. And it's caused by coronary artery vasoconstriction. So remember that the first two branches off the aorta were the right and left coronary arteries. Then they each branched into two branches that supplied the heart. So we, especially in a young heart, we talk about four major arteries supplying the entire heart wall. That's where a quadruple bypass comes from if all four of those arteries are blocked. Triple bypass, three of the four, double, and so on. So it's these coronary arteries that we're talking about. So because the coronary artery on a temporary basis is constricted, it causes the signs and symptoms of ischemia to the heart wall, and that presents as chest pain. So the difference here is that it's variant, it's not predictable, and that's why it's considered basically an idiopathic kind of etiology. Nobody's quite sure why individuals go through this, but it is associated with an increased risk for heart attack without us knowing exactly why this happens. Most of these vasospasms are probably going to be discovered to be an autoimmune type of response, but it hasn't been clearly outlined yet, so it hasn't been clearly understood. Now you can have some cerebral artery vasospasm, which is secondary to hemorrhage. So the hemorrhage, the blood exposure to the cerebral artery causes a vasospasm. Otherwise known as a stroke. Some of you may have heard of a condition called Raynaud's. Raynaud's syndrome or Raynaud's condition is, again, another example of an idiopathic scenario where there's vasoconstriction So the vasoconstriction occurs in the peripheral digits in response to cold or stress. So you can physically look at these people that are experiencing a Raynaud's episode, and halfway down their fingers, there's a demarcation. There's a definite line between what is pale or cyanotic and what is pink and healthy looking. And I've seen it multiple times with people that come out of the swimming pool or the lake, especially if they're exposed to a bit of wind or the cool air. And if you look at their digits, they're cyanotic about halfway down the digits, and then the rest of the hand looks perfectly healthy and pink. That's Raynaud's. The vast majority of people that have Raynaud's, it's idiopathic. A smaller percentage of people that have Raynaud's is secondary to smoking. The smoking, the warm cigarette seems to be a trigger initially for vasodilation that results in a rebound type of vasoconstriction. It's a bit of a mystery why some that have that exhibit that particular set of symptoms, but it does happen. And some migraines fall into this category. Migraine headaches. So this is caused by vasospasm of, again, cerebral blood vessels. Especially on the back side and underside of the skull. The occipital area is a common area for this cerebral blood vessel vasospasm to occur, giving rise to these migraine-type headaches. You can have structural problems with the blood vessels, so that's the end of our vasospasm examples. So we can have other issues with the blood vessels. We can have a valve incompetence that's going to give us varicose veins. We'll talk about that in just a minute. We can have conditions that result in hardening of the blood vessels, arteriosclerosis. We'll talk about that in a minute. We can have weakening of the blood vessel wall, called an aneurysm. And you can have scenarios where the blood vessels mix. There's what's called an atriovenous fistula, a pathway between the venous and arterial circulations. And those all have their inherent sets of signs and symptoms and risk factors. We're going to start by talking about some valve problems, varicose veins. So varicose veins typically present as superficial. So they're going to show up superficial raised veins. So these are not a diagnosis, they're a description. So just because you have some raised veins doesn't mean that they're varicose in nature. But if they also have valve incompetence, that interferes with venous return, and causes edema, now we have a diagnosis. So just the presentation of superficial raised veins is not the issue. There has to be some valve incompetence that interferes with venous return and causes some swelling, edema. Now we can talk about varicose veins. So who's at risk for varicose veins? Generally speaking, females are more at risk than males, which is unusual for cardiovascular issues. More often than not, males are at higher risk for cardiovascular factors than females are. This is a small exception to the rule. Other factors are factors that anything that increases pressure outside of the veins is therefore going to interfere with venous return. So pregnancy does that. Obesity does that. Sedentary does that. Aging, prolonged standing. So these increase pressure that interferes with venous return, right? If we increase pressure, abdominal pressure, increase external pressures on the veins, they're not going to be as effective at returning. And the sedentary factors increase stasis, and that interferes with venous return. So if we interfere with blood flow, we're going to interfere with venous return. This reduces the muscle pump. If you have faulty veins, incompetent veins on top of not being physically active, you're really dramatically going to have a negative effect on venous return because we're dependent on those skeletal muscle pumps and those competent one-way valves in the veins to encourage venous return back to the heart. So the most common cause is this sedentary factor that reduces the effectiveness of the skeletal muscle pump, pushing blood back towards the heart. That's going to promote the edema and the decreased venous return. If it's chronic, it's going to result in stiffening of those vessels as a result of the backward pressure that's being applied to them. It promotes edema because of the flow in the veins, creating a concentration gradient between what's inside the blood vessel and what's outside of it. So we're going, in the interest of equilibrium, we're going to try to push water out of the blood vessel into the interstitial space. That's the definition of edema. That edema gets worse every day. So again, if you're standing or sedentary all day long, the edema becomes more noticeable as the day goes on. Sometimes you get some skin pigmentation because the smaller venous ruptures occur and red blood cells are allowed to leak out, and the heme from the hemoglobin as it breaks down leaves a brownish, darkish hue to the skin in patches around the areas where the leakage occurred. What are we going to do to treat? Well, the first thing is look at our risk factors, and if there's anything in those risk factors that are modifiable, we want to address them. So we can modify our sedentary lifestyle, we can modify obesity. Pregnancy, in theory, is a temporary thing. We can affect our standing for prolonged periods of time. So those are all things that we would address. Resting and elevating, I shouldn't say resting, becoming active and elevating instead of standing. So when you're going to stand for a length of time or sit for a length of time, elevate the legs, get the ankles up closer to the level of the heart. That will help with venous return and take pressure off of those veins in the lower limbs. So we want to address the modifiable factors. And when we say address, we want to remove them. If we can, if we have that option. Can't do much about aging, can't do much about the difference between males and females. Pregnancy is temporary, so we try to use all of the factors we would use to address the modifiable issue during the pregnancy. So stay physically active, elevate the legs when you're sitting down. Those sorts of things would help to minimize the effects of the pregnancy that causes that extra pressure. Weight reduction is a big one, and we know that if possible, we would like to avoid surgery, but in some cases, surgery can be done to try to remove to create some drainage of the chronic edema, if that's the issue. Some of the varicose veins can be removed, but when you remove varicose veins, you have to be aware of the fact that you're removing some of the capacity for venous return. If there are just a few of those superficial veins and those veins are already incompetent, then it probably doesn't have a big impact on venous return, but it is a consideration. Okay, we're going to push through arteriosclerosis, and then we'll take a break. Okay? Everybody okay with that?
Yeah.
So this name tells you everything you need to know. It affects arteries, and the sclerosis refers to a hardening of the arteries. What that really means is a loss of elasticity. So one of the important vessels that are under pressure is that they have some elasticity. We know that if you stretch a blood vessel, especially on the arterial side, the smooth muscle will contract against that, and it creates a bit of peristalsis, moves the blood along the length of the artery. If we lose that feature, it's going to be more difficult to maintain blood flow, and it's going to increase the risk for things like thrombosis and embolism and other complications related to blood flow. So it's hardening the arteries for any reason. One of the most common reasons is atherosclerosis, which is the formation of an atheroma, which is essentially a fatty mass. So this is a process that we used to think was a middle-aged problem, and it led to complications like heart attacks and strokes and other cardiovascular challenges. But we recognize now that it probably starts as early as our teenage years, even more so now than 20, 30, 40, 50 years ago. And we can thank the families of the McDonald's and Harveys and Wendy's of the world that promote foods that are high in fats, but probably more importantly, high in sugars, for the earlier onset of this process of atherosclerosis. Begins in our teenage, early 20s, and progresses over several decades before it presents. So it's a slow to develop, but serious complication, often related to lifestyle factors that are choices we make that create this atherosclerotic situation. So for the formation of these atheromas to start, the first thing that has to happen is we have to have some sort of endothelial surface damage. So you remember that the endothelium was our inner lining, and then next to the endothelium, which was our tunica intima, we had a thicker layer of tunica media, smooth muscle cells. So if we have a scenario where we interrupt or we damage the intima, now we have exposure of the underlying media to the lumen of that blood vessel. So we've got an endothelial surface damage that's going to initiate the inflammatory response is going to attract monocytes, white blood cells. The monocytes are the ones that are going to become macrophages, big aggressive eaters, to this location. And the inflammatory response also promotes an increase in permeability, which is going to increase the likelihood that we're going to expose the contents of the blood vessel to the layers below it. So the tunica media and the tunica externa even are possibly going to be affected by this increase in permeability. Remember when we talked about the inflammatory response, chemicals were released that promoted vascular permeability and attracted white blood cells to the site of the injury, right? Everybody's okay with that.
Yes.
Okay, and we're going to get attraction of platelets. Remember when we talked about tissue repair in a blood vessel, it's going to start with platelet plug formation. So the second part of the puzzle is the availability of cholesterol. So the carrier of cholesterol to the periphery is known as a low-density lipoprotein. So low-density lipoproteins deliver cholesterol to the site of the injury. And oh boy, do those monocytes get excited about that. So what's going to happen is we've got some platelets. Well, actually, I'm going to make the cholesterol, I'm going to make it yellow because fat is typically kind of yellow. So we'll make platelets green. So we got platelets that are trying to create a clot. I'm sorry, they're going to try to create a plug. So they're trying to plug the area up. And the other thing that happens is with exposure to the underlying media, we get some smooth muscle cells that infiltrate into this mass as well. And the monocytes become phagocytes, and they try to engulf. They're trying to digest, endocytose, and degrade the cholesterol. So under a microscope, they start to fill up with cholesterol. And when a monocyte or phagocyte becomes filled with cholesterol, it gets described as being a foam cell. And it's just because it looks, the contents of this phagocyte looks foamy under an electron microscope. And the foam cells give the intima, the lining of this blood vessel, a yellow streak that we know is caused by the fat. So this is a fatty streak. Early on in the formation of this atheroma, we get the presence of these fatty streaks. They haven't really impacted the lumen of this blood vessel yet, but it's a progression. So then our smooth muscle cells and our fibrocytes infiltrate the site in an interest of trying to repair. And when fibrocytes infiltrate, they start to lay down some collagen. And the collagen, what they're trying to do when they lay down the collagen is trying to stabilize this clot, stabilize this mass of cells and tissue that are the atheroma, early stages of the atheroma. So what we get in our progression here is the foam cells, which were made from cholesterol in the macrophages, the fibrocytes, fibroblasts, or fibrocytes, and the platelets grow and form the atheroma. So all of 1, 2, and 3 result in the formation of an atheroma, and the atheroma is otherwise known as a plaque. You'll sometimes see the atheroma called a plaque in more sort of in a more day-to-day type of description. The atheroma is known as a plaque. And plaques can be stable or unstable. When they're stable, they've got a nice fibrous capsule. So they're not likely to break. So when we look at the inside of the we got a bunch of fat in here. The fibrocytes came along and they laid down a nice capsule. If the capsule is a nice, thick, complete capsule, that would be described as a stable plaque. If we looked at the lumen of the blood vessel and we noticed that this cholesterol and the fibrocytes and so on formed a cap that was incomplete, maybe it was free on one side, then that's described as an unstable plaque. That's more likely to be able to break away. So it has an incomplete fibrous capsule. So that's a little more dangerous. That's a little more of a concern. Now, you're not going to see this. This is asymptomatic. It takes a growth of this plaque to take about 80% of the lumen away before it becomes symptomatic. So as this grows, and it may take decades, as it approaches somewhere, let's say, anywhere from say 50 to 60% occlusion, may be symptomatic. But it's going to have to be somewhere in the vicinity of 80% occlusion to be symptomatic at rest, and maybe more. There are people that go in to the hospital with some chest pain. They have an angiogram done of their 4 coronary arteries, and they can have 80 to 90% of all 4 of those arteries blocked. So 4 of those arteries, 80 to 90% blockage, and they're still walking around. They're able to walk in to the hospital and say, you know what, occasionally I get some chest pain. Now, they're the lucky ones if they can walk in and do that. Sometimes with an unstable plaque, what's going to happen is it's going to break off, become an embolism, and if it breaks off and finishes in a coronary artery, it causes severe damage beyond that blockage site. If it's a big enough part of the heart, you have a heart attack that doesn't allow you to survive. Right? That's the concern with this type of atherosclerosis and the mechanism of it growing slowly and asymptomatically until either an embolism occurs or more than 80% of the blood vessel that it's growing in has become blocked. So what happens then with a blockage is we get bigger and bigger till the hole is blocked except for, say, 15 or 20% of the blood vessel lumen is available for blood flow. And in this area that's available for blood flow, there's going to be a lot of turbulence. You can appreciate that if we looked at this blood vessel in a lateral view, this clot that's been, this atheroma is taking up 80% or more of the lumen. So if I just prevent this from spreading everywhere, There's our blood flow. So you can appreciate that in this area, as blood flow comes in and it's supposed to leave here, there's going to be a lot of turbulence. And if we get a lot of blood turbulence, what that does is trigger the coagulation cascade. Remember, coagulation cascade was those intrinsic and extrinsic factors that resulted in the formation of prothrombinase. And prothrombinase worked on prothrombin to make it thrombin, and thrombin worked on fibrinogen to make it fibrin, gave us a good, strong, insoluble clot. But in this case, we don't want a clot because a clot is going to result in a complete blockage. Then we're going to have ischemia on the other side. And the problem with that clot is it might break off on its own and become an embolism as well. Are you following the mechanism here? Yes, no? Have I lost you? Did I ever have you? Of the 11 of you that are here right now, are you following me okay, or is this confusing?
Follow.
You following? Is that what you said?
Yeah.
Okay, all right. So let's carry on. Who's at risk? What are the risk factors for somebody developing an atherosclerosis? Oh, so let's just go back to this for a second. So the other thing to be aware of, just when we're looking at this picture here, is here would be our tunica media, the smooth muscle layer. And because this atheroma grows into that layer as well, we're going to lose elasticity. That's where the sclerosis part comes into play. With the added collagen and remodeling that occurs in both the intima and the media, we lose elasticity. So we're describing the development of an atheroma that leads to a type of hardening of the artery. The cause is the LDL and the injury to the tissue combined with the reactions from the cells that are attracted to the site from inflammation. We get hardening of this area, loss of elasticity. So, oh, okay, we don't need that in this picture here. So, risk factors for atherosclerosis. Smoking. That's a big one. What we know smoking does is it actually has elements in the contents that will be directly involved with damaging the endothelium. So some of the additives to cigarette smoke have a direct effect on damaging the endothelium, and the smoke itself has a negative effect on the integrity of the endothelium. So this is where, in this respect, any kind of smoke, it could be campfire smoke, it could be smoke from marijuana, smoke from tobacco, smog, any of those things will increase the risk for damaging the endothelium. And we know that chronic smokers also change their lipid profile. So we see an increase in circulating LDLs and a decrease in circulating HDLs. HDLs are the lipoproteins that take cholesterol from the periphery and bring it back to the liver, and the liver can destroy it if the homeostasis of cholesterol is adequate. So we like the HDLs because they reduce peripheral cholesterol. LDLs increase the peripheral cholesterol. Smoking also increases blood pressure and increases your heart rate. So these are all things that will aggravate blood flow and promote turbulence and the atheroma formation. So we also know that people that have been diagnosed with metabolic syndrome, which is sometimes also recognized as pre-diabetes, especially type 2 diabetes, but diabetes type 2 especially, obesity, again, the sedentary lifestyle, being exposed to chronic stress, high trans fats. No other dietary factors have been attributed to the onset, or at least have evidence base for onset of the formation of atheromas except the trans fats. So sometimes you read, especially old literature, indicates that saturated fats are bad for you, and the thought was they promoted atherosclerosis. The reality is that they don't. But trans fats, which are manufactured fats, synthetically produced fats, they do. There's a correlation between a high intake of trans fats and the formation of atherosclerotic plaques. So these are all examples of modifiable risk factors. Non-modifiable are an increase in age, males a little bit more than females, not as much as was once thought, and a family history. So diagnosis is going to start if you have some symptoms. So if there is enough blockage that it's affecting performance, in other words, exertion or challenge results in early fatigue, and you otherwise have this profile, then you might undergo some diagnostic testing. Now, the diagnostic testing has to be able to look at blood flow. So there is a technique called the Doppler technique, which is able to listen to blood flow. It's like an ultrasound of your blood vessels, and it picks up turbulence. So wherever there's a little bit of an interruption or an invasion of the lumen, the nice open pathway for the blood vessel, there'll be some turbulence. The Doppler picks that up. An angiograph is typically going to be done where a stain is introduced to the bloodstream, and then we can follow the change in color, or watch where the stain does not distribute, and that's an indicator that there's a block that's preventing that stain from getting through, or it gets through on a thin stream as opposed to a full diameter of the lumen, an indicator. And you can also have, this is a very non-specific, but an exercise or stress test, where you're just challenging the body, increased oxygen demand. If you're unable to go through the expected stages of the stress test, it's an indicator that there's blockage somewhere. So last topic before we take a break, treatment. What do we want to do first? What's the first thing we want to do as a line of treatment? Same as before. What do we want to remove?
The modifiable factors.
Yes, modifiable factors. Lose some weight, get active, avoid those trans fats, stop smoking. Those sorts of things are what we're talking about when we say remove the modifiable factors. The second level of treatment is through medications that are designed to modify or change the lipid profile. Now, these medications do not work effectively unless you're also addressing the modifiable factors. So the great results you sometimes see from a medication that's designed to lower cholesterol levels only lowers those cholesterol levels to that degree if the person is also exercising and eating effectively. So statins are a class of medications that decrease cholesterol with exercise, weight loss, and good nutrition. So statins are a class of medication that they address cholesterol levels, mostly by trying to lower the LDL levels and prevent the peripheral distribution of cholesterol out to the cells. That's the main way that they work. There's different variants that are trying to influence the ratio between HDLs, make more of those, and relatively less of the LDLs. And medications that are designed to lower blood pressure. Lower blood pressure is another treatment approach for trying to control the growth of these atheromas once they've been identified. And then the next level would be more invasive. They involve making changes to the integrity of the blood vessel itself. So with angioplasty, you're altering the patency of the lumen of the blood vessel. If you have a blood vessel that has a blockage, one thing we can do is we can insert a structure that has a balloon, literally a balloon. So this is inserted into the blood vessel that has the blockage, and then the balloon is inflated. And the inflation of the balloon is designed to kind of squish the atheroma and push it back against the intima to open up the lumen of that blood vessel. Then when the device is removed, we're going to have a squished atheroma, which will take another decade or so to grow back, in theory. So we bought some time. In a much older patient, this might be a treatment of choice, because although it's somewhat invasive, much less invasive than doing some sort of a bypass surgery. So in a 75 or 85-year-old individual, this might be a treatment of choice. This is called a balloon angioplasty, and it compresses the atheroma and reestablishes the lumen. So we open it up. In another example, we can address the atheroma by inserting a stent. And what a stent is kind of like a wired cage that's designed to compress and expand or keep. It's kind of like a tube that's inserted to keep the blood vessel open. It'll compress the location of the atheroma and keep the blood vessel open. So now we've got reestablished a pathway for the blood flow by this cage that's been introduced to open things up. And the more invasive type of angioplasty is coronary, or is most commonly used on coronary arteries to bypass them. So if we have a coronary artery that looks like that and is blocked, what we do is we take a blood vessel from another location and we bypass that area. So now the blood flow is allowed to travel down and pass the area where the blockage has occurred. When you hear about somebody who's had a double bypass or a quadruple bypass, this is what they're talking about. So these are more invasive with varying degrees of effectiveness. In both of these cases, they're often temporary, although temporary might mean several years. And again, depending on your patient profile, that might be all that somebody is expected to require in order to, as in combination with their lifestyle changes and so on.